Howdy, folks, and welcome back to Healthy Humor. This is your host, Doc MB. Before we get into the episode, I wanted to introduce you to a few of the terms that we use throughout. Terms like autonomy, birth equity, informed consent, shared decision-making, and intervention rates. I'll begin with autonomy, informed consent, and shared decision-making as they are all very closely related. Autonomy is essentially just our right to make our own decisions for ourselves. When it comes to medical practices, what we usually look at when we think about autonomy is the patient's right to have a say in their medical care and not just listen to, maybe a singular option that is presented to them, but to really have all of the information, which leads us into informed consent. Informed consent is when we have been given all of the options. We know the risk factors associated with each option. And then when we get into shared decision making, that's when we take that informed consent, all of that knowledge that we have, and then we utilize our autonomy to make a decision for ourselves. But with shared decision making, the idea is we're partnered with our care team. Hopefully, it's your doctors, your nurses, whoever else might be part of the patient's care team has given them all of that information, made sure that they have informed consent, and given them the power to have autonomy over themselves and to feel like they know that they're making the right decisions and discuss it with their provider. And that's when we get back into, again, that shared decision making. And then when we, moving on, we talked about birth equity. Birth equity is making sure that everyone has equal access, equal opportunity, but most importantly, equal access to the information and to quality care, health care and support throughout their pregnancy, throughout the birthing process, and certainly within their postpartum care. Now, we also talked about intervention rates. Intervention rates would be, the rates at which maybe the birth process is not going quite the way we wanted it to, and so now we have to intervene with something like a C-section. If there is no intervention necessary, it means that most likely the birth went extremely well and there was no need to step in with anything else. And that is usually ideal. And, we discussed some of the reasons that an intervention might be needed in this episode. If you are curious about any other terms we used or for information regarding any of the websites or organizations mentioned throughout this episode, please check the show notes. I will be including a lot of information there. And if there's something that you were curious about that maybe I forget to mention in the show notes or that I didn't cover in this intro or that we did not cover in the episode, please leave a comment or email me at docmb@healthyhumor or healthy-humor.com. Thank you. And I hope you enjoy this episode. Howdy, folks.
Hi.
Welcome back to Healthy Humor. I'm Doc MB, your host, and I have the lovely Sandy Lawrence with me today. We know each other because I went to school with her kids, and we've stayed very close ever since.
That's true.
So I brought her on today to talk about her experience being a midwife.
Well, I'm not actually a midwife.
Oh.
But I've worked in midwifery.
Okay.
Yeah.
Her work in midwifery.
Yeah.
And specifically as it pertains to autonomy for female patients.
So. Yes. So I'm Sandy Lawrence. I'm not a midwife, but I have worked in a midwifery center, women's birth center, and an out-of-hospital birth center. I've birthed in an out-of-hospital birth center.
Okay.
And I sit on the national board for the accreditation of birth centers in America. So okay. I have a lot of experience. I've been with my friends as a doula. I've been a birth photographer, and I've done a lot of self-education for midwifery.
So I now have a follow-up question.
Yeah.
Actually, I think I have two.
Okay.
You're saying midwifery, and I said midwifery.
Yeah, I think you can say it either way.
Okay.
Yeah.
I think making sure.
Just fine.
Okay.
And now, keep in mind, I lived in the North for a very long time, so everything I say sounds different.
That is true. And I didn't know if it was that or if it was one of those things that, you can say it either way.
I think you could say it either way.
Okay. Perfect. Just don't want to upset anybody.
No.
Yeah.
You won't.
Okay, good. So I guess my next question then, you said that you have worked as a doula.
I have worked as a doula.
So what's the difference between a doula and a midwife?
A doula is an individual support person. A doula will not deliver.
Okay.
the baby. They're there as a support to the birthing person,
Okay.
strictly as support.
Okay.
And a doula will do things like advocate for the mother as she's birthing. If like, especially they can be especially great in a hospital situation if you're hoping to have a natural birth in a hospital, um, or if you and you want just a little bit reinforcement, a doula can really help with that. A doula will stay with somebody from the moment they go into the hospital or go into labor until the baby is delivered, which is something OBGYNs often don't do. So in a hospital setting, it provides a consistency.
Okay.
And then it's also just really, like I said, support. Like, because if you're in labor and something is not going the way you had anticipated, it's great to have a person who's one step removed from the emotion. And I think that's where a doula can come in really handy.
Yeah. It would seem it would also, because not everyone has a strong medical background or
Right,
understanding.
right.
It seems like a doula would also be able to
Right.
help with that,
Yeah.
translation of whatever they're saying.
And it takes some of the pressure off the partner if you've got a partner in there with you, because nobody is thinking outside of the absolute moment that you're in. So whether it's wonderful and everything is going the way you want it to, or if you're having to make some changes or you're having to make some decisions, having somebody there who can step back and explain it as a buffer can be really helpful.
Okay.
Yeah. And they can be the one to go out, run and get you ice chips, or in my case, red peppers, because that's what I wanted to eat when I was in labor with one of my kids.
Like spicy red peppers?
Yeah, just like red bell peppers.
Oh, okay.
Yeah.
Okay.
Yeah, everybody has their thing.
Yeah. It's,
And you don't know till you're there. For sure.
No.
So.
No. I've got a lot of friends who are just entering into that phase of life. Yeah. And the stories I've heard so far, I'm like, wow, everyone is different.
Totally different.
So different.
Totally different, yeah.
And I've had quite a few friends who have done, I have had friends who have done a birthing center. I have friends who have done the C-section, the planned C-section, the emergency C-section, we're going to keep it as natural as we can, but still do it in a hospital setting.
Yeah.
And all of those people are individuals who either, not all of them, how should I say this? The ones who chose, not to do it in a hospital, to do a birthing center, or to do it as naturally, whatever that means for them in a hospital, they did it because they knew someone else who had done it that way, and that's kind of how they got into it. But a lot of people, the only thing that they know is the very traditional, you go to your OBGYN, and then that's who carries, or who is handling your care all the way through. So what are our options?
Okay, so I think the difference between, and full disclosure, my first child was born in a hospital with an OB, and it was an unmedicated birth, and it was great. Like I had a great birth. My second child was born out of hospital in a birth center, a freestanding birth center, and it was amazing. And my third child was born in a hospital in Minnesota, with a midwife as opposed to an OBGYN. And it was, I had wanted to have an out of hospital birth, but it wasn't an option at the time in Minnesota. So it was not great. But so our options, I think, for most women, most people who are having a baby, will be, you've got your traditional OBGYN route. You have what we call certified nurse midwives. Most of them are also nurse practitioners. And they often practice in hospital settings, but they can also practice in a home birth or a birth center setting. And then you have your certified professional midwives, or sometimes they're called direct entry midwives. And those are women who, I don't know how to put this without it. I don't want it to sound dismissive, because it's not. It's more of an apprenticeship program. Okay. So it's kind of like the difference between going, your CNM, your certified nurse midwife, nurse practitioner, has gone to college and gotten an RN and then gotten on and has a bachelor's or a master's, or this nurse practitioner formal. And a direct entry or lay midwife, direct entry midwife, or certified professional midwife will have gone through, there's generally there's still an education process, but there's also like an apprenticeship process. So they might be a student midwife for several years. And then after a certain number of births and a certain number of hours, then they can take their test to license and those kind of things. Now, a CNM and a CPM are both fully qualified to deliver babies.
Okay.
And to help women through the process. CDM or a CPM, direct entry or professional midwife, do not deliver in hospitals in most states.
Okay.
Because they don't have specific clinical training for hospitals.
Okay.
So you're going to see a lot of CPMs and CDMs in home birth practices and birth center practices.
Okay.
And you'll see the birth center I worked for, we had a mixed model. So we had CPMs, we had CNMs, we had nurse practitioners, and we delivered in the hospital, at the birth center, and in homes.
Okay.
So it's really.
So our direct entry, the less formally educated ones, they are certified. It's kind of like they don't have a medical license. They're not licensed with whatever the state's medical board is.
Right.
So that definitely would explain then, I guess, why they can't work.
And they may have a midwifery license, but that varies very much from state to state.
Okay.
Where we have, national boards for physicians and national boards for nurses and some of those things. The CPM, CDM is, it varies more state to state.
Okay.
Yeah. And actually your care in midwifery, midwifery care is pretty standard across the board, but what kind of care you can have with a midwife varies from state to state as well. There's no real national standard for that.
Okay.
Some states are really open about birth centers and home births, and some have very restrictive licensing, things like that. So really, it's about educating yourself what your options are in your community.
Right.
And Tulsa's got some nice options. I mean, we have the Tulsa Birth Center. I've heard wonderful things about. I haven't been there. We have the Tulsa Birth Initiative, which is a fantastic group that is working to make sure that we have birth equity, which is important.
Yeah. Would you like to speak on birth equity
birth
for
equity,
a moment?
sure.
It's a term I'm familiar with, but I know.
Yeah, probably not a lot of people.
Yeah.
Well, just things like a lot of things, are people of color, marginalized communities, underserved communities, immigrant communities are not privy or not given necessarily the same level of education as your traditional middle-class white woman who has private insurance.
Yeah.
And there's a disparity there. Women of color are much more likely to be deemed high risk. They're more likely to be have a C-section, a non-planned C-section. They're less likely to be, especially for Black women. It's much higher mortality rate, and there's a lot of studies that say these women are not listened to by their doctors.
Yeah.
And so often they think so often the choice for people within these communities, the only choice that's presented is you can go to a doctor.
Yeah.
And that's not true. Even if you don't have private insurance, say you have Medicare or Medicaid, Medicaid covers nurse midwives and often will cover birth centers.
Okay.
But that's not an option that's presented very often to people. So that's what I'm talking about when I talk about birth equity, is we want to see all women have the choice to make the birth decision that works for them. That's my big passion within it, is birth choice, birth education, birth choice.
Yeah. Well, and then, I mean, that goes back to our autonomy over our health decisions in general, and just having that education, or just, like you said, having all of our options in front of us and knowing what they are.
Well, so you can inform consent. I personally, so I've delivered in a hospital, out of a hospital, with drugs and without drugs. And never had an epidural, but that doesn't really matter. But I honestly don't care if, when you choose to have a baby, or if you decide to have a baby, whatever. If you want a scheduled C-section at 37 weeks, that wouldn't be my choice. But if you've if you've done all of the education and you choose that, that's your deal.
And it's not just your physician.
It's not just your
doing
physician.
it because they're going to go on vacation.
Right. If you want a free birth in your backyard under a tree, again, your deal.
Yeah.
I wouldn't necessarily recommend it, but if you've educated yourselves on what those risks are, that should be your choice. And those are things I feel really passionate about. In the middle there is everybody else. You know, those of us who will say it's your first baby and you're not sure, but you're like, man, I want to be in a hospital, but I like the idea of midwifery care. That's, you're looking for a practice that has a C&M.
Okay.
Or a hospital that has alongside maternity unit, which is a maternity unit that operates under midwifery care standards, which are a little bit different than OB standards.
Okay.
And so, that would be what I would tell you, is like, education is extremely important.
Yes.
Read everything you can about birth, read the risks of a planned C-section, read the risks of a vaginal birth for a breech baby, which it can be done. Read about the risks of birthing with an epidural and without an epidural, and what do the drugs do, which drugs pass through the placenta, which drugs are just, there's so much to learn. And generally we're not getting that information.
Right.
And I find, having worked in midwifery in an administrative capacity, and then being having my own children through midwives, 2 out of 3, that midwifery tends to be more holistic and tends to take into consideration like the whole picture of a woman's health, as opposed to just the uterine, vaginal canal parts of things.
So what are some of those other health factors that are being considered whenever someone's using a midwife or using midwifery care?
Well, so midwifery care is like, most women, most birthing people, most people can birth a baby just fine.
Yeah.
Whether they want to do it with drugs or without drugs, our bodies were meant to do this. This is what, for the majority of people, our bodies do it just fine. Midwifery will take into things like account, and in all birth care, it should be taken into account your nutrition level, your activity level, whether you have any chronic diseases, whether you have any autoimmune diseases, but that doesn't rule you out from midwifery care.
Okay.
Because interestingly, some of the autoimmune diseases that we see in women, say lupus, MS, ulcerative colitis, those kind of things, those autoimmune, fibromyalgia, those autoimmune disorders will actually take a back seat when a woman is pregnant.
Wow.
And we would see people who have MS, who are pregnant, who are feeling the best they've ever felt in their lives. And for instance, I have a family member who has autoimmune hepatitis. Okay. And she is currently pregnant again, and her pregnancies, she has never felt better. And it's just remarkable how our bodies like kind of figure that out, take care of your body. Midwives will take that into consideration. You're also going to take into consideration things like your ethnic background, your BMI, and doctors will too. OBs will too. Yeah. But there are risks associated with being underweight, and there are risks associated with being overweight, and then that's just to take everything into consideration in midwifery is the goal, because then a woman can probably birth pretty safely,
right,
how she wants to.
Yeah.
So that's my passion with that. I just think we ought to all know everything about it.
Yeah.
Yeah.
No, I mean, I agree, and not just about midwifery, but just health in general, and health education. Yeah. And I mean, that's the whole point of this show, and the work that I do at the university. I mean, that has been my passion for a long time. as you know, I've had my own health things that have gone on, and I wasn't always given all of the information.
Right.
And I either had to go out and find it myself or make a snap decision with not enough information. And it didn't feel like this shared decision making process with myself and whoever my provider was. Not every time.
Right.
You know, obviously,
but sometimes
some that have been amazing.
Yeah.
You know, and for the most part, I've gone through more traditional channels and insurances and everything.
Yeah.
But there are other options.
There are other options.
Yeah.
And for midwifery care, I think that the difference that I have seen is, and some of you might understand this, like if you've been through this, you go in for your OBGYN appointment, you get measured by your nurse, and you get your fundus height checked, and you get all this stuff, and then all of that's done and recorded by your nurse or your nurse assistant or your whatever, and then the OB will come in and be like, yep, looks good.
Yeah.
In midwifery care, there are still nurses that will come in for your appointments, but your appointment is with a midwife.
Okay.
And the midwife will be the one doing the measuring, doing the cervical check, doing the and generally that's a little bit more time with the patient or with the expectant parent. That's been my experience.
Yeah.
And when you're in labor, whether you're in labor in a hospital, in a birth center, or at home, backyard, wherever you're doing this, if you're birthing with a midwife, unless your labor was going 40 hours, and then that would be a whole different situation anyway, but a traditional, like regular labor, your midwife is there from the start until the end.
Yeah.
They don't switch at shift. And I found that's a great thing that makes it, you just feel more comfortable.
Yeah.
If you don't have to explain yourself a second time.
Exactly. And labor is not an easy time.
No, it's
even
not
when
easy.
It's a healthy
labor.
Yeah.
Yeah.
So, and I would imagine, I mean, thinking about my own experiences or just thinking about anyone else that I know, that having your midwife be with you, not only for the whole time during your labor, but thinking about all those checkups you talked about, if they're the one that's primarily handling everything and you feel that much more comfortable with them, then when you are in labor and if something does get a little hinky or something needs to be explained, you have a higher level of comfort.
Right. And a higher level of trust. Like you're going to, there's been a lot of studies, I probably can't quote them all, but if you have this kind of trust relationship with your provider, you're right. If something isn't going the way you'd hoped, you're going to be more receptive to your midwife saying, hey, Mary, I know you wanted to have this baby out back, but that's not going to work. So we're going to go ahead and we're going to transfer you to the hospital, but no, I'm going to be there with you the whole time. And that's going to be a much better situation than somebody you don't know coming in and saying, prepping you for a C-section, we'll see you in 10. And not that happens very often, but it does happen. And having that level of trust, you can make an informed decision. So say you were planning to have a baby without any interventions, and you find out you're going to have a C-section for whatever reason, and there are very legitimate reasons to have a C-section. Knowing you have that trust with this person, you can make that decision in stages as opposed to reactionary, because they have your best interest in mind as well, and the health of your baby.
Yeah.
And I think
and you're not a stranger to them.
You're not a stranger. Now, a lot of practices will have multiple midwives, but at least the practices that I've been involved with, even if you have multiple midwives, you're going to meet all of those midwives, not just once.
Okay.
Probably 2 or 3 times.
Yeah.
And usually you'll have midwives who will often work in pair. So you might have a primary, but you're going to have one of your other midwives is going to be there, and her too.
Okay.
So those are some of the advantages I see.
So instead of, what you see a lot of times with traditional medicine, where the doctor is either trying to schedule that C-section, or if they're out of town, you are just seeing a stranger.
You're just seeing whoever's on call.
Yeah.
If you go in at 2:00 in the morning, you're going to see who's ever in call.
Right.
And they can do a great job. I mean, that's just no doubt about it. And OBs and OBGYNs, they're, specialized in this whole thing. But I remember this is how I got into midwifery care for myself, was my first child, and it was a great birth. It was a very good birth. I was in a hospital because I was 26 and I just thought that was my option. And it was at my 6-week checkup. I went in for my 6-week checkup after my baby was born. Your friend, Jill. And I said, Dr. Adams was my doctor's name. It was in Alaska. And I said, I've been doing more reading throughout this whole pregnancy and this postpartum period. And what do you think of midwifery care? Like,
yeah.
And he said, Babe, I didn't go to medical school and to Mayo Medical School and specialize in gynecological surgery to have women like you walk in and have a baby and walk out. He's like, you're really pretty boring. I think midwifery would be perfect for you. So, and I thought that was great.
Okay.
Because he was like, no, we have midwives for a reason.
Okay.
I'm here if something goes wrong. I'm here but you, yeah, you are why midwives are here.
Okay.
And that gave me the comfort to say, all right, well, I'm going to pursue midwifery the next time. And I only wish I'd done it first, honestly, but you don't know.
Yeah, you don't know.
You don't know. I know a lot more young women who are choosing midwifery care, whether it's in a hospital or out of a hospital now, like your age. But I think, again, it's 28 years ago, I didn't have the same level of education available.
Right. Do you think that there's also maybe the education is easier to find now?
I think it's easier to find, and I think there's less of a stigma.
Okay.
Midwifery is accepted more, and now that we have more information about what happens around the world, like in the Scandinavian countries, midwifery care is the standard, and OBGYN care is reserved for women who are high risk.
Okay.
Here, everybody goes to an OBGYN. The outliers go to the neonatologist or a midwife. And I think that you'd see it around the world, midwifery care is really kind of the standard for things because it works. Recovery time is quicker for most women. Yep, your body just seems to, when you're not, I don't know, just seems like
you're more comfortable.
Yeah. Your body's doing what it was supposed to do. And if your body's not doing what you're supposed to do, if you're informed and if you've been taught to trust your body, you're going to be able to feel that, and you're going to be able to advocate for yourself as well, which is something they really highly, highly push in the midwifery practices I've worked with.
Yeah.
So,
do you feel like a midwife does and not necessarily a better job, but do you think that they're more oriented towards the education side?
Yes.
Component? Okay.
Yes, I do. That's been my experience. Now, I haven't had a baby with an OBGYN for a long time, 28 years. So, but I did have my third child in a hospital with a certified nurse midwife. And that was, I felt like the education, the risks, the being told what my options are, what my risks are, was offered to me in my midwifery care practices in a much more, these are the options as opposed to this is what you should do. And I think that's the big difference that I've seen with midwifery.
Okay.
These are your options. And these are your risks. These are the rewards. These are, these are your personal risk factors. These are, and if you've got a good midwife, and I would say most midwives are good. I would say most OBGYNs are good, but if you've got a good midwife who's got a good relationship within her community, with hospitals, with other providers, you're in a safe place.
Okay.
Even if you end up having to have an emergency C-section or a transfer.
Yeah.
Which doesn't happen a whole lot. Like right now I was pulling stuff up, and I think our national C-section rate is, so the World Health Organization, the WHO says your ideal C-section rate for women would be 10 to 15%. 10 to 15% of women would ultimately end up having a C-section for reasons that are necessary to have a C-section, whether it's a pre-existing thing or if it's something that happens during throughout the birth process. Now, in 2023, the U.S. national C-section rate was 32.4%. It's a huge difference.
And how much of that was not because it was necessary, but because it was more convenient?
Probably 20% of that, 15
Yeah.
20% of that 34% is what I would guess. I know that the midwifery I worked with in Alaska, I think our transfer rate for women who were birthing at home or in the hospital was birth transfer and C-section rate was 11%.
Okay.
Which is falls within those parameters. I mean, there's some women are going to end up having a C-section or going to have interventions that they didn't plan. But the fact that I think, it just is, that's just been the way it's done, the way our healthcare system works. It's easier to schedule a C-section, it's easier to schedule an induction, but you're not, it just, and it's fine. It's fine to do those things if you know the risks.
Right.
Like, for instance, a midwife is not going to say, well, you're at 38, 39 weeks. Let's just go ahead and induce you in 5 days. Because if your body's not ready to be induced, and pregnancy is a range.
Right.
38, 37, 38, 37 to 42 weeks is considered a normal range. So you've got it. That's a big range. And a midwifery, most often in midwifery practices, you cannot deliver outside of a hospital past 42 weeks, which makes sense. That's when your amniotic fluid starts to break down and the baby's more likely to have meconium, different things like that. But in some OB practices that I've seen, they'll say, well, your due date's on March 12th. If you haven't had that baby March 15th, we're going to induce.
Yeah.
And
why?
Right. If you want to be induced, that's great. But if you go in and you're induced at March 15th and your cervix is at 2 or 3, the chances of you ending up with a C-section are much, much higher than if you had gone in on March 17th and your cervix was at a 6 or a 7. So that's just kind of general rule of thumb. Once you get past 5, you're less likely. But if you're induced before your body is ready, you're risking complications because your body's not ready.
Right.
And obviously, if there's extenuating health circumstances or if the baby's in distress, those are all different things. But for your normal, standard, everyday pregnancy, you have a lot more of a window there than we've always been told.
Yeah, I was gonna say. I mean, again, I've had a lot of people in my life recently that are going through either they've already had kids, they're pregnant with their first, some of them are pregnant with their second, some even their third already, but they've all kind of at some point been told, if the baby's not here yet by that date. And my understanding is that date is kind of arbitrary anyway, because it's not based actually from the sperm met the egg. It's just from your
cycle, and that can be totally different. Women's cycles can be anywhere from 21 to 32 days depending on who you are.
Right.
And interestingly, and I can't quote this, I can't quote it, so just believe me. The more regular you are in your cycle, the more likely you are to deliver close to your due date.
The more regular?
The more regular.
Okay.
So if you are a 28-day start to finish, your menstrual cycle goes from 1 to 28 days, and again, too much information, and hopefully my children don't watch, but in my case, it was on Tuesday. If I didn't have my period by 2:30 on Tuesday, something was wrong on the 4th Tuesday since the last time I had it. Literally 28 days by 2:30. And when I got pregnant with my first, it was we had been hoping to have a baby, so we were watching for things. I came home, and my husband was from work that day, and I came home, and he was like, "You got your period?" And I'm like, "No." And it was 7 o'clock at night, and he goes, "Well, we probably better go check things out.
Yeah.
And sure enough, I was pregnant.
Okay.
And I delivered on my due date.
Mm-hmm.
And it was the same with each of my kids, which way I was like, well, my third, I didn't know I was pregnant for a while because I was it was ridiculous. I just was in denial. But when you go back, yep, my kids delivered like pretty much spot on. And the more regular you are, the more likely you are to deliver closer to due date. Okay. So if you have shorter cycles, you might end up a little shorter.
Okay.
And if you have longer cycles, you might end up with a little bit longer, which accounts for some of that range.
Yeah.
Yeah.
Wow.
Yeah.
It's
totally interesting.
Yeah.
It's so fascinating.
It really is. Well,
Yeah.
What I also find interesting, one of the first thoughts I had was, I don't know anyone who is that regular either.
Right.
Like everyone I know who menstruates,
right,
is not that consistent.
Yeah.
And not just like, obviously, yours was by 2:30 on that Tuesday, but even just, females, we talk to each other, we communicate, and the number of friends that I've had, or sometimes not friends, sometimes they're just kind of acquaintances, and they share things with me.
They'll just tell you things.
Yeah. But if they're late by, some of them even up to 2 weeks, they're like, that's not that irregular for me.
Right.
And I don't know if this is something that's becoming more prevalent,
I think
or
so. I have theories, but
I also
I have no medical proof. I have absolutely no research to back it up, but we could talk about diet and nutrition and how some of those things I think are a problem, and chemicals screw with our bodies, but
yes,
that's a whole nother thing.
Yeah, and we can talk about that for hours.
We can.
That's for the wine after the show.
Yes.
Yeah.
That's right. Or some long rambling session.
Right. That's the live stream episode.
Okay, we'll do that someday.
Yeah.
That would definitely need one.
Yes, for sure.
So not Lent. Has to be after Lent.
Yes.
Yeah.
I know.
But so that's kind of where I'm at. I don't have a whole lot of like hard facts. I have a lot of lived experience with this kind of thing.
Right.
And it's
hard facts are great, but I always want hard facts coupled with lived experiences.
So this board that I sit on, it's called the Commission for the Accreditation of Birth Centers in America. And what we do is we literally go into birth centers that are either opening or have been open, and we have a list of what they call indicators. That are benchmarks that they have to meet to be accredited.
Okay.
So you can open a birth center in the U.S. and not be accredited.
Okay.
But accreditation will say, okay, we're adhering to these standards, we meet this level of care. And that in turn is favorable with their insurance companies, with Medicaid, Medicare, anything that's some insurance companies won't reimburse if you're at an unaccredited. Some states will say if you've got accreditation, you don't have to go through a licensure process because we know it's already the standard is high and we don't have anything to add to it, so we'll automatically give you a license. If you're accredited, you get a license. You choose not to be accredited, then you have to go through a licensure process. But of course, that varies from state to state. So what we do is we go through and put out these standards, and then we follow up and we do like a site visit where we make sure that standards are being met. Safety, fair billing practices, community engagement, that the birth assistants, the doulas, the nurses all have training in neonatal resuscitation and what to do. And the birth centers are doing drills to make sure, like if they have to transfer somebody, or if there's a tornado, or if there's, something's happening during a birth, what you do.
Right.
And so, but that's the professional side of what I do.
Yeah.
And it's fun. I like that. I like knowing that we have a standard for birth centers. I think we have something like 114 accredited birth centers in the U.S. It fluctuates because every year some go up, some go down. There's a lot more birth centers than that.
Because they're just not accredited.
Right.
Okay.
Yeah. And in some states, the licensure process is pretty rigorous. And although I'd love to see all of them be accredited because I think it's a great check and balance. Some state their licensure is so it meets or exceeds our accreditation, and then you can feel pretty comfortable that that's a safe situation as well.
Okay. So if someone was interested in finding out if, going through midwifery care was right for them, where should they start?
I would say start with, you could go to the CABC, which is the Center or the Commission for the Accreditation, and that's literally, let me get there.
I'll share the link
Yeah.
for any of this.
It's the
in
Commission
show
for the
notes.
Accreditation of Birth Centers, and it's, birthcenteraccreditation.org. Also the American Association of Birth Centers. Let me make sure I've got that right. AABC. And they are the professional group of they're like the professional group for birth centers. Lots of birth centers are affiliated with the AABC. About a third of those birth centers are accredited by the CABC, but we do work together.
Okay.
So we are the independent accreditation. They are the professional group. Both of those websites can give you a lot of information.
Okay.
And in your own community, I'd say go to, here in Tulsa, go to the Tulsa Birth Initiative and Birth Equity website. They're fantastic. And also check out your local birth centers.
Yeah.
I mean, that's one way to do it too. And check out what options there are at some of our hospitals. I know some of our hospitals have, we don't have any what we call alongside maternity units, which are they're practicing midwifery care, which means they're not scheduling epidurals. They're not, their midwifery is pretty non-invasive. But we do have hospitals that have birthing suites and rooms that are more focused on the mother, that give you a little bit more choice, where you might have the choice to be laboring in water or on a ball, or rather than just your standard hospital birth room.
Okay.
So it really comes down to, we've got so much education we can get out there now. It's phenomenal that what we can access.
Yeah.
I'm trying to think, I can't remember what her name is, and I really should know, but one of the premier certified professional midwives, I believe she was in Kentucky. And she just has trained thousands of certified professional midwives and direct entry midwives. And I mean, she's just like a birth goddess. I don't know what else to say. She is really like the mother of the movement and it used to be, if you said you were going to have a midwife or you're going to birth out of a hospital, you were just a crazy hippie. And for some of us that may be true, but I think that is changing, and I think that's important.
Yeah.
And I would research, if you're looking to get pregnant, if you are pregnant, if you're thinking about midwifery, look at the difference between, look at the Scandinavian countries. They have been doing midwifery as the standard of care for the majority of women for a very long time. A very long time. And they have great birth outcomes and low C-section rates.
Right.
And low intervention rates. And those things are important.
Yeah.
I think.
It must be nice to be a developed country that doesn't have the same infant mortality
Yes.
rates and maternal mortality rates as,
some of the underdeveloped countries.
Yep.
Yeah, for sure. For sure. I know one of the women she's my favorite midwife in the whole world. Her name is Karen Braun, and she's retired now, but she's worked in Alaska and in Arizona. She's had birth centers in both places. And I believe she did a lot of work right on the border, the U.S.-Mexican border at one point, and delivered hundreds of babies in birth centers that were for women who otherwise wouldn't have had that choice. And that's good work. It's important work, and we're seeing that around the world now. We're seeing midwives really get in there and help. Yeah. And some of that is breaking down the stigma of certain cultural stigmas around birth and our bodies. And,
right.
Well,
I mean, thinking even, so I was born in the 90s, and in the 90s, I can't imagine anyone conducting an interview where they so openly talked about menstruation and the different options for birth. I mean, we're coming into this new age where we can
And we
talk about it
should.
openly.
We
Yeah,
should. Absolutely, we should. And our partners should be a part of that, and they should be. I know with my first baby, it was just like I said. I mean, I was kind of curious about midwifery, but I didn't really know it was an option. And my husband was like, "No, no, 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 no. That's just so scary, so scary." And so we did have him in a hospital, oldest in a hospital, and that was, like I said, it was fine. But then going into midwifery care, I think the biggest convert in our family for midwifery care was not me, it was my husband.
Okay.
Seeing the difference in the care and the treatment, um, the actual birth process. Well, he missed the first birth, so he can't really see that, but he did see the care and the he went to appointments with me and ultrasounds with me and all that for the first baby. And then for the second baby, well, and he missed the birth, which is a whole nother story, and we can talk about how important it is to have a doula or a trusted friend there, because you never know what's going to happen. And then for my second baby, I did completely out of hospital, and I was actually with a direct entry midwifery group in Alaska. And that just the difference in the level of care and the personal aspect of the care, and then the actual birth process itself was so different for me and for what my husband saw, that it was just he was the one who was saying, yeah, you just go to a midwife.
Yeah. Well, and clearly you had a greater comfort with midwifery care.
Yes.
And, that might not be everyone,
right.
But because that was true for you, what he was also probably seeing was your entire experience in the back end, and not just the way you were treated, but, how at peace you were.
Right. My comfort level.
Exactly.
And
which ultimately probably led to his comfort level during some times.
The best thing, this is a complete aside, and again, it's like not medically anything, but the best thing was after my second child was born, my first child, who was 2.5, he was there about 15 minutes after my second was born. And he hops right up on the bed and he takes a look at his little brother and he says, does he walk? Does he talk? Does he play in the dirt? And that would have never happened in the hospital.
Yeah.
That wouldn't have happened in the hospital, because that baby would not have been in my arms 15 minutes after birth.
Right. It would have been.
I mean, but there I was, my family got to see my baby before they took him off to get him weighed and all those kind of things. Right. And that was really an incredible experience too.
Yeah.
And I very much appreciated that. And that's a big difference for me with midwifery care, is that you are more involved as a woman too. I know many midwives who will say, reach down, do you want to deliver your baby? Because I'm not delivering your baby, you're doing the work. And will literally encourage a mom to slip her hands under her baby's shoulders and pull that baby to her chest. Now, you can do that in hospital too. You have to work a little harder.
To advocate for yourself. Hopefully maybe have someone there to advocate for you at that time.
Right. Okay. And I was able to do that with my first child, which was amazing. But then to be able to do it with my second and not have him taken away was phenomenal.
Or not have to push as hard to be able to have that option.
Right. To just like, well, what do you want to do? Where do you want to be? Do you want to be in the tub? Do you want to be on the birth chair? Do you want to be on, instead of, you're going to be here and we'll break down so you can sit up a little bit and then have your baby. But, it just, the freedom that midwifery offers, I think, is very comfortable for women, makes women very comfortable, much more comfortable during the birth process, which is hard, can be very hard.
Yeah.
And for the most part is manageable, and is what our bodies were designed to do. Sometimes people go, it doesn't hurt. Well, it does hurt, but it's not like breaking a leg. Right. Because that's an unnatural thing. You're going to break your leg, you break your arm. That's completely unnatural. For me, and what I see in other people's experiences, it's intense. It's painful, maybe. Some people, just depends on what their pain tolerance is, and their level of pain and how they perceive pain. But it is work.
Yeah.
It's a lot of work, and it's also, but if it's going well, you feel like you're doing what you're supposed to do.
Right.
And then that's another thing I think with midwifery is, if it's not going well and you're with a midwife, you can look at your midwife and say, something is wrong. I don't know what it is. And a midwife, in my experience, has been more likely to say, tell me what you're feeling. Let's see where this is. Let me check. Where it, I've seen women in other situations say, you're just fine. Just wait, through another push, or just hold your breath or whatever it is, and dismissing that instinct. And I think we do have that instinct. And I do think we need to be able to, the freedom to express that. And I think that's midwifery offers that for a lot of women.
Right. Well, and you mentioned earlier the statistics about especially women of color, even more specifically Black women, that are not listened to or have especially their pain, dismissed. But
I mean, all across the medical,
all women too.
Right.
It's not just women of color, but it is significantly higher.
Yeah. And infant mortality and maternal mortality is higher too. Just having concerns dismissed happens a lot more often, which is disgusting. Awful. Just awful. And on that note, totally not midwifery related, but kind of. You need to do an entire podcast on pelvic floor therapy.
Because it's on my list.
Oh, good. Good. Because that is something that is being offered to women now as part of postpartum care. That was not offered to women in my generation at all. You were just told, well, you had a baby, so when you run, you're going to pee. Well, it doesn't have to be that way.
Right.
And thankfully, that's becoming a recognized and sometimes even covered by insurance thing.
Yes. And I know some people who have gone and done pelvic floor therapy even beforehand.
Yes.
To help make sure that everything is kind of ready.
Yep.
And in that way, the recovery on the back end goes smoother.
So much better.
Yeah.
So much better. And I think that's that. Yeah. And I'll watch that episode for sure because I think it's so interesting. And I think I have a niece who's a Air Force pilot.
I've met her.
And you have met her. She's delightful. And she says that she said, if I had to do it all over again, I would probably be a pelvic floor therapist because of the difference it made in her recovery from her first to her second.
Wow.
And it was just, she was like, it's just remarkable. It changed my life, and it really can. And it can make it so much. Your recovery is going to be better. Your experience going forward is going to be better. Your experience sexually forward is going to be better. Yeah. Face a whole lot of things with a lot less fear if you know your entire body is strong and you can jump on a trampoline with your kids without wearing depends, which is, real for a lot of people.
Yeah, it definitely is.
Yeah. But
I know this was a lot of fun. Was there anything that you really wanted to speak on that we didn't get a chance to cover?
Just take the time to be informed and ask people. Ask your friends, ask older women in your life what their experience was like. If between my generation and my grandma's generation, they all birthed in a hospital, except my grandma probably birthed at home on the farm. So if you have women who are a few generations, ask what it was like. Because it has changed so much. And from the 50s to now, we medicalized birth so much that we're kind of swinging the other way, and I think that's good. I think it's good. And we have things in place where if a woman's high risk, if a person who's birthing is high risk, and they need the interventions, they're there, and we're thankful because C-sections have saved lives, mothers and babies. Hospitalization for hemorrhaging absolutely saves lives. These things save life. And having the choice to, if you're healthy, your body is doing what it needs to do, midwifery care can also save lives. Just having that broad spectrum and really, really doing your homework is so important. I would say, especially if you're a woman of color and if you're young, that's another area of where young women, you're looking at teens, even early 20s, you're going to be dismissed probably a little bit more. You're probably getting to the age now, the advanced age of almost 28, or you are 28, right? One of the two, where you'll be taken seriously. In that, and you're educated, so you'll be taken seriously. I was 26 when I had my first, and I looked young.
Mm-hmm.
And I mean, until my doctors knew my age, I was treated very much like, how have you gotten yourself in this situation? Uh, as such a young woman, I'm like, well, I've been married for 5 years and I'm 26 years old. I mean, I thought it was kind of time to have a baby, you know.
Yeah.
but that is another thing. So if you're young, if you're single,
Mm-hmm.
um, you know, if you're choosing to have a baby on your own, or you just are having a baby on your own because
Right.
your partner split or whatever happened, um, the best thing you can do is advocate for yourself and find somebody trusted who can be alongside you.
Yeah.
And learn.
Right.
And go to pelvic floor therapy. Stay active. Drink a lot of water.
Get enough sleep.
Get enough sleep.
Yeah.
Drink a lot of water.
Yes.
Don't change the cat box.
Yes. Don't do that. I mean,
change the cat box.
don't bleach the shower.
Right.
Yep.
Right.
All of those things.
Those are good things.
Yeah.
Well, this was fun. Thank you.
Yeah. Thank you.
Yeah.
And like I said, I will put everything in the show notes for
I'll
today.
send you those links and
Yes.
stuff too.
Would love that.
Yeah.
And
And if
then-
you don't air it because it was awful, I'll understand.
No. I will definitely be airing it. And I will go ahead and tell the audience, have a happy and healthy day.
Yes.